السلام عليكم ورحمة الله وبركاته. عساكم جميعا بخير وصحة وسلامة. معكم أخوكم. I'm an assistant professor at the UNC Adams School of Dentistry in the state of North Carolina in the United States. And I would like to take the next 45 minutes or so to share with you my presentation titled State of the Art Dental Cements. How do we make sense of it all? And so over the last years, there's been many cement systems that have been introduced into the market, and it can get really confusing to the average clinician السلام عليكم ورحمة الله وبركاته. عساكم جميعا بخير وصحة وسلامة. معكم أخوكم تيسير سليمان. I am an assistant professor at the UNC Adams School of Dentistry in the state of North Carolina in the United States. And I would like to take the next 45 minutes or so to share with you my presentation entitled State of the Art Dental Cements. How do we make sense of it all? And so over the last years, there's been many cement systems that have been introduced into the market, and it can get really confusing to the average clinician to understand, select which cement is optimum for use for each specific case. And so, sometimes it gets to be overwhelming, and I think we can all get a sense of craziness, especially with the vast majority and mass production of these cements with minimal information, minimal clinical evidence on whether they work or not. And so this presentation is really meant to help guide you into the selection of the proper cement system for your specific case, for each specific restorative case. And so just by definition, according to the glossary of prosthodontic terms from the Journal of Prosthetic Dentistry, you can see a luting agent is any material used to attach or cement indirect restorations to prepare teeth. A dental cement is a material that on hardening will fill a space or bind adjacent objects. That's just by definition, according to the and so I'd like to start off by saying that currently there is no cement that is ideal for every situation. We wish we had that golden cement where you can use it for every case, but that's not in reality yet. And so that's why we have to understand the different types of cements that are available to us and how we can make the best selection for each specific case. But what do we want out of a cement, out of a luting agent? First of all, it must not harm the tooth or the tissue. It must allow sufficient working time to place the restoration. It must be fluid enough to allow complete seating of the restoration. And it must quickly form a hard mass strong enough to resist functional forces. And it must not dissolve or wash out and must maintain a sealed interact restoration. And so, again, over the years, we've had many cements that have been introduced to us as clinicians. And you see, it is overwhelming from the different types of cements that we have. But let's focus on organizing our thoughts a little bit here. If we classify the cements into conventional cements, we can see that the zinc phosphate polycarboxylate, the zinc oxide eugenol glass ionomers, and even the resin modified glass ionomers all fall under the category of conventional cements. And then we have the resin-based cements, which we can classify them according to their curing method into chemical cure, light cure, and dual cure. And then also cements can be classified according to their bonding mode. You have the adhesive resin cements and you have the self-adhesive resin cements. So now we've organized our thoughts a little bit and we've classified the cements according to these different classifications so we can understand them better. But as you all know, since 1850, the first introduction of zinc phosphate cements, up until 1970, we only had one cement. And it worked for every case at that time. In the 60s, the zinc polycarboxylate cements were introduced, followed by the glass ionomers in the 70s, and we had the resin-modified glass ionomers after the 80s were also introduced. But then, after the 1990s, we had an explosion of different resin-based material that were introduced to us. Some of them are in the self-adhesive mode, some of them are in the adhesive mode, and so that's where all the confusion really started happening. This is a nice table that shows you what we're looking for in terms of a luting agent or a cement. You can see the different types of cements are available onto your left. And then you look at their setting time and their strength and solubility, how it bonds to the tooth structure, how easy it is to remove any excess cement. And then the area of fluoride release, I wouldn't really focus on that area a lot. There's a lot of advertisement now about bioactive cements and fluoride cements. Any bioactive material or fluoride releasing material, they're good initially when you place them on the tooth structure. After a few hours, that declines. The only way that these material are successful in releasing fluoride is that you recharge them with fluoride constantly, and then they act as a reservoir to release fluoride. But that has to be done constantly with high concentrations of fluoride. So really, it is not a practical way of doing it. It's been proven and reported in research that any of the bioactive materials, any of the fluoride releasing materials, they're good initially, but then that property drops after a few hours to a day or two, and so really it renders useless for in that sense. So I wouldn't really be caught up on the hype of advertisement about these terms and get too excited about them. But you know, as we can see here, that from the resin-based cements or the adhesive cements, they are the strongest cements. They bond very well to the tooth structure, and so those are the cements that we're really going to focus on in the next few minutes. And so we like to base the selection of our materials on evidence base. So what evidence base do we have on dental cements? And so there's only a very few clinical trials. There are many in vitro testing of the cements. There are a lot of opinion articles. You have experts in the area that would share their select these a specific cement. And then we have history of successful use, word of mouth. How successful has this cement been for you? And you report that and you share that with your colleagues and in other meetings and study clubs. And so that's kind of a way to understand or to learn more about cements. But why are clinical trials so difficult? If you think about it, if you're going to do a clinical trial on a cement, you have to think about how much time are you going to require to follow up on this restoration. Look at the covariables in the study that you're going to set up if you're doing one on cement. Teeth are different. The preparation designs are different. How do you take the impressions? What's the fit of the restoration? What's the quality of the lab making the restoration for you? Oral hygiene, diet, parafunctional movements, all of these can really play a major role into the outcome of the studies. So it's very, very difficult to control clinical trials for specifically focusing on dental cements. And you know, how many subjects are you going to include? What is the definition of a successful outcome versus a non-successful one, considering all these variables? So that's why conducting a clinical trial on clinical cements is going to be and so my focus today will be on, we're going to review the components and properties of dental cements. We're going to identify the pertinent types of contemporary cements, evaluate the effects of different dispensers on physical and their mechanical properties. This is a study that we have published a lot on. And I'm going to provide for you a guide at the end of the presentation on how to each cement for each specific case or for each restorative material. We go back to our classification according to the conventional cements, the resin-based cements, and according to their bonding mode. I'm going to start off first and foremost by the convents. They are still around. They still have a place in our world. I'm not going to go into the about zinc phosphate cement, nor am I going to talk about the zinc polycarboxylate cement, glass ionomers. These are all cements that have been used historically and have been really replaced. For example, resin-based material. But glass ionomer cements are still around. They're formed of powder and a liquid. And again, as you know, aluminosilicate glass along with the polyacrylic acid, water, tartaric acid, that's the very basic composition. Glass ionomer has a true chemical bond to the tooth structure. And so that is something to take into consideration when you have there's a chemical interaction that happens between the hydroxyapatite in the dentin and between the polyalkylinic acid and between the carboxyl groups of the polyalkylinic acid. And so the true chemical bond happens with glass ionomer material to the two structure. And that is something very, very but we know that the glass ionomers, they have adequate aesthetics. They have poor physical properties. I'm talking about the conventional glass ionomers here versus the resin modified ones. And then they do have a good adhesion to the two structure. They are somewhat technique sensitive. You have to have proper isolation and etc. Fluoride release, I'm going to put a question mark behind them because of the how I explained or talked about this topic of fluoride release just a few minutes ago. Then we had the resin-modified glass ionomer. Sumita Mitra was the first who introduced fluoroaluminosilicate glass with a photosensitizer. The polyacrylic acid works as a copolymer, and then there's HEMA, also that has been added along with photo initiators. Here, I don't know what's going on in this diagram, but again, as a clinician, all I need to understand this material is how does it react. There is an acid-base glass ionomer reaction. That's the traditional chemical reaction. And there's a formation process and also a chemical polymerization process. So resin-modified glass ionomers undergo these three reactions before they set. Resin-modified glass ionomers, they have adequate aesthetics, improved physical properties compared to the conventional glass ionomers. They do have proper adhesion to the tooth structure because I said there is a true adhesion to the dentin. They have improved handling, and then fluoride release, advertised heavily by manufacturers, but have very minimal effect after it's been cemented for a few days. And then I'm going to ask you a question here. You probably all have realized that resin-modified glass ionomer, for example, Reliax lutein, was introduced first as a powder and liquid version. And then it came out as a clicker where you squirt out paste A, paste B, and then you mix it on the slab. And now we have a version of it, which comes with an auto mix tip. And so there's something that came up to my mind once, and I was looking into this, and I was saying, you know, changing the dispensing method of this cement have any effect on the physical, mechanical properties of the cement? Because I was thinking in order to change the cement from a powder liquid, an automix version, there might have been some changes in the chemical formula in order for it to be dispensed in an automix version. So I'll share with you some of the results that we found out, which was quite interesting about the effect of the difference in dispensing method on the property. And so that was the ultimate question here: is does the change in the dispensing method affect the cement property, which I will show you towards the end. And so now we understand the conventional cements, the different types of them. What evidence base do we have that these cements are successful or not? And again, like I said, very, very minimal information. This is a report from the Dental Advisor, which reviews the properties of a lot of the materials, and they've conducted many clinical trials as well. I do appreciate the information that the reports on a lot of these materials or techniques that come from the Dental Advisor. So you can see we did 116 restorations. Most of them were crowns. They followed up to 7 years in the patient's mouth. And so out of the 100 restorations that came back for evaluation, the aesthetics scored 99 out of 100. Resistance to marginal discoloration, 97 out of 100. Retention, only debonded out of the 100. So remember, these are crowns that have proper resistance and retention form. They use resin-modified glass ionomer cement to cement these crowns. And so the outcome was quite phenomenal. Reliax lutein Plus showed a very, very nice outcome for the ones that they followed up to years. And so what we can conclude from conventional cements is that the clinical success of full crowns with conventional cements are excellent, provided adequate resistance and retention form. That is a must. When you have a crown preparation that has optimum resistance and retention form, form, don't worry, no cement. They will work fantastic. You're relying on your retention and resistant form, and so you don't really have to use an adhesive cement for this process. Okay, so conventional cements work phenomenally well when you have proper resistance and retention system that you're going to use it with. That's how you're going to make the right selection of the cement for that specific case. So it all comes knowledge about the material, which will lead to optimum selection. And then you have to know how to apply it very well, and that will prolong the durability of your restorative outcome. That is all what we're aiming for, is how do we provide longer restorative outcome for our patients and provide better service for our patients. So the focus here is going to talk about a little bit about the composition of the resin cement, how it is cured. We'll look into the clinical recommendations for each type of resin-based cement, and then the application. So you can see it is in a nice and sequenced manner here. But if you look at the composition, very simply put, we have inorganic fillers that can range between 60 to 70 by weight. There's an initiator that initiates the chemical or the light curing setting reaction. And then there's silica. And so that is the very basic composition of any resin-based cement. Now, when we talk about curing of resin cements, they're either cured self-cured, so chemical, which is composed of a two-paste system, and it relies on an etch or a self-etch system for a structure. So these are usually self-etching by nature. That's how they bond themselves, the cements bond themselves to the tooth structure. And we the chemical cure or self-cure cements under areas where light cannot penetrate the material, like under a PFM crown, under using them. And so when you are doubting the light curing process, it might be good to select a cement system that is self-cured only, okay? So you don't have any light component in it. Main examples of events that dominated in this area, we have the Panavian one by Curari, and also we have the Multilink Automix from Ivoclar. And you can see they come with their own bonding systems that are added to the tooth structure and also added to the restorative material that you're going to use. So you must follow the instructions very carefully when you're using these types of cements. Then we have the light cure resins, and so they have an extended working time because they're light cured only. So if you don't hit them with that, therefore they're called setting on demand cements. They have improved color stability. These cements do not have the tertiary amine component in them. So therefore, when you're using this cement under a very thin restorative, like a veneer, a very thin restorative material, you want to use a light cure cement that is stable in color, does not have tertiary amines in them, and therefore they will not with time. Okay, so that's why we use light cure cements only under very thin ceramic restorative. Examples of light cure only cements, we have the Verilink veneer from Ivoclar, Reliex veneer from 3M is another good brand, and then we have the Permashade from Ultradent. These are just examples of cements. There's many other manufacturers that make, but I can't. But specifically here at the school at University of North Carolina, we are using the Reliex veneer from 3M, and also we have the Verilink available in our graduate program. And so the third type of the cements that we have is the now, these are indicated under restorations that can attenuate light. When you have a restoration that you think light passage is limited, but it does pass, but not fully, then I would consider using a dual cure cement. It's also two pastes, and also the color darkens with time due to the tertiary amine component. This is a light cure and a chemical cure component that are combined together. The chemical cure component has the tertiary amine in it. So therefore, it is going to change in color with time also. So you have immediately you're going to start to think dual cure cements. Should I use them underneath a thin ceramic material? Absolutely not. It will change in time, just like because of the chemical cure component and then the tertiary amine component in the chemical cure section of the dual cure resin cements. Examples that we have here is the Reliax Ultimate from 3M. You have the Panavia V5 from Curare, the NX3X from Kerr. Again, multiple brands. There's many available in the market. I'm just sharing with you, specifically we use the Reliax Ultimate and the Panavia V5 here at the school. These again were based on a committee sitting down together and looking into the literature, looking into research, and then also out of the expert opinion on which cement to use, because we always best materials to be used by the students so that when they graduate, they know the quality of the material that they're using is going to be very, very important. And so we want to set that standard very high for them concerning. And so, you know, dental adhesion really falls under the category of system you're going to use. So these dual, when you're using an adhesive dental cement, they come with their specific system. So I'm not going to go into the details about dental adhesion, but you must follow the directions properly. Whether you apply the primer on the tooth structure or the ceramic primer on the ceramic material, you just want to make sure you follow the directions very well. Time is important. How to clean, how to air dry, how to rinse is also very important. So when you're using an adhesive cement that comes with its own adhesive system, you want to be very, very careful onto following the directions. Small clinical tip here. I haven't had the time really to include in this presentation about preheated composites, because it's a composite material. It's a light cured cement. It can be used as a cement material when it is warmed, so it will lower the viscosity of the composite material. You can use it in combination with the 3-step etch and rinse system on the tooth structure or the 2-step self-etch system. I always do a selective etch of the enamel, and then if you wanted to use a preheated composite, one of these systems, highly recommended, of a separate prime and adhesive. This is on the tooth. On the ceramic, you follow the instructions of the cement. If you're using an Ivoclar product with Emax, you want to use the Monobond Plus. Treating the ceramic with a ceramic primer is different. This is only, I'm talking about how to use a preheated composite as a luting agent, and then for your tooth structure. So you want to use an adhesive system that we know the composite will bond very well to the tooth structure. And to the tooth structure has always been with the 3-step etch and rinse or the 2-step self-etching adhesive systems. And so again, these dual cure cements, the tertiary amine with a photo initiator, paste B has the benzyl peroxide in it, and so they're mixed together to give you a nice and uniform consistency. Storage of these dual cure cements are very important. Again, I'm trying to share with you details on how to maximize the outcome of your work through selection and application of your materials. If your material, very simply, is not stored properly, the efficiency of the material is going to go down, and therefore it's not going to give you a proper outcome. So you want to pay attention to this. So you're storing these dual cure, 18 to 22 degrees Celsius. The working and setting times can be affected by storage temperature. So if you have a cement in your hand that sets really fast before you even had a chance to clean it, don't blame the cement immediately. You look at how you were storing that cement, because that can really affect the setting time. And so that will shorten your ability. If multiple teeth at one time and you're placing your cement in multiple crowns, it will shorten work time, and therefore it will be very difficult for you to cement these. If you're relying on the auto cure or the self-cure component of the cement alone, that is not sufficient to achieve maximum cement hardening. There's been a misconception about dual cure cement, saying, well, I use the dual cure cement under this crown, but I didn't subject it to the light curing unit because it has the chemical cure component that will set. Yes, the chemical set, but however, it won't reach to its optimum levels. So you have to combine that with the light cure. It's a combination of two. So therefore, you have to have the chemical cure component and also the light cure component that will maximize the setting of the cement. Now, if you ever thought about this, If you have a dual cure cement and you placed your crown very quickly, cleaned the margins, and then you cured it with your light cure component, the light curing process can paralyze the chemical component of the cement to work. And so we're currently working on a project right now with one of our residents. Actually, she's from Saudi, Dr. Bashair. One of her project was, does the effect of curing time affect on the bond strength and also on the properties of the cement? So we cured it immediately, then after 2 minutes, after 5 minutes, and then after 10 minutes. We delayed the curing process. We wanted to give the chemical component of the cement its time set or to work before hitting it with the light. And so that is something that is, and so what we came out with a recommendation is that it is advisable to delay the light curing procedure of the dual cure cement 5 minutes. Okay, so when you're using a dual cure cement, place your restoration, take your time. Between 2 to 5 minutes is the optimum time for an adhesive or a self-adhesive cement before hitting it with the curing light. Less than 2 minutes, don't hit it more than 5 minutes with the curing light. That's when the best bond strength and the best because you're going to give a chance for the chemically cure to work and also with the cure component to work as well. And so those cements that do not cure properly will have an adverse chemical reaction and permeability issue. That's why we see a lot of these dual cure cements sometimes when they debond, it is a problem that this cement probably did not set. It was either not stored properly or you didn't cure it properly. It did not set. You didn't have a proper isolation. So before jumping to blaming the cement and the cement, we have to look at ourselves and look at what we are doing wrong before making any conclusion on the material that we're using. So if you really wanted to overcome the issue and using dual cure cements, and if you're not sure, if they haven't been successful in your hands, again, going to use a preheated composite system. You warm your composite, lowers the viscosity, use a 2-step etch and rinse, a 3-step etch and rinse, or a 2-step self-etching system on your 2 structure. Use your ceramic primer or your metal primer on your other end, and then just go ahead and place them and then cure at one time. That has also been shown to be very successful and the outcome. So let's talk about in dual cure cements, we have self-adhesive cements. The first self-adhesive resin cement was Reliax Unisem from 3M. It is the most researched self-adhesive cements. These cements have isomers. They have fillers that neutralize initial low pH, and they have a dual setting mechanism. It's a dual setting a dual curing resin cement. So it's formed of dimethylmers, just like we said before, inorganic fillers. There's an initiator, silica, because they are self-adhesive cements. There's a functional acidic monomer that is added to the composition of cement so that the dentin and prepare the dentin. So if you're using a self-adhesive resin cement, you don't have to use another adhesive system with it. Actually, it's recommended against it, because if you're using an adhesive system, you should be using an adhesive cement. But when you're using a self-adhesive resin cement, then you don't have to use anything besides preparing the tooth, preparing your ceramic, and then bonding the two together. So there's a very delicate balance between the acidic hydrophilic monomers in the cement and then the conventional hydrophobic monomers and existing already in a dual cure resin cement. And so let me show you what happens really when you are using the self-adhesive cements. So you're using a cement that you're applying, the self-adhesive cement you're applying surface. The self-adhesives, of course, they are self-etching. They have a low pH. We need that pH to be low so that it can demineralize, partially demineralize the dentin and the tooth structure. So this low pH is going to demineralize the dentin. It's going to enhance the bond to the tooth structure. Therefore, for the self-adhesive to penetrate deep into the dentinal tubules, it has to be hydrophilic, and that will increase the wettability on the dentin surface. Okay, so that's how the self-adhesive works. When the cement hits the tooth structure, the tooth will increase the pH back to its normal level. So the initial pH was low. It enhanced the demineralization process. That's all we want it to do. We want the tooth to neutralize the pH, and therefore it will lead to, this system will lead to a low pH environment that enhances the bond strength to the tooth structure. So therefore, initially the cement was hydrophilic, so it can penetrate deep into the dentin. Once it hit the tooth structure, the pH went up. The cement changes to becoming a hydrophobic material because it's, I don't want it to be hydrophilic now. I want it to push or to become water resistant, so that it become soluble. So it needs to become hydrophobic. Okay, so that's how these resin cements, or the self-adhesive resin cements, work. So you understand that, I think you will have a better appreciation of how these materials form and how they work. So again, I'm going to go back and say that these are dual curing resin cement. The self-adhesive are dual curing. Light activation could interfere with cell adhesion, and like I said, it's always advised to wait 2 to 5 minutes. If you don't have penetrating through the material, that's also going to compromise the efficiency of these cements. And so we want to delay the light activation as possible between 2 to 5 minutes. Now, you saw that this is a delicate process. The polymerization process was delicate between low pH hydrophilic to becoming increase in pH and hydrophobic. So what are the factors that can affect this polymerization process? So what if you're not cementing onto a natural dentin, right? If you have enamel or an amalgam or any core material, what's going to happen is that the neutralization of these acidic monomers is really going to go down. You're going to have increased acidity of the environment there. The polymerization is not going to happen as well either, and so therefore you're going to have water absorption. So if you think about it, when you have an amalgam base, when you have another composite that's covering dentin completely, it's not going to be that wise to use a cement, because self-adhesive cement relies on having natural dentin available so that this process, chemical process, or the polymerization process happens optimally. So that's something to really consider when you have a core substrate of a different material other than dentin. It's not advised to use self-adhesive cements, because that will lead to degradation of the cement faster because of the water absorption process, and also it will delay the polymerization process as well. Self-adhesive cements are stored between 4 to 18 degrees Celsius. Keep that in mind. They're not like the conventional resins I said was 1822. 4 to 18, they have to be refrigerated, and that will affect the working time and will affect how long you have to cement multiple crowns if you're doing so. Please store them very carefully. When we look at the mechanical properties of these resin cements, we'll classify them according to the following. Conventional resin cements are the strongest, the conventional ones, okay? Then it's followed by the self-adhesive, and then followed by conventional cements. So conventional resin cement is the strongest, followed by self-adhesive resin cements, and then we have the conventional cement. Now we've talked about conventional cements. We've talked about the resin-based cements, whether they're dual cure, a light cure, or self. Okay, let's take a look at our surface treatment protocols. How do I optimize the surface of the tooth structure and also of the material that the indirect restorative material that I'm going to? So let's start off with the enamel. Enamel, if you're using an adhesive cement, you always want to use selective phosphoric acid etching, and then you're going to use a bonding agent, whether it comes with the cement, or like I said, if you're using a preheated composite, you can use an adhesive system. Bond FL for the 3-step etch and wrench, SE Bond 2 from Kurari for the 2-step. Fantastic adhesive systems that can bond the composite to the tooth structure. And then you can, again, these adhesive cements are either light or dual cured for thicker ones. If you're using a self-adhesive cement, this is quite interesting. Also, you can do phosphoric acid etch. Remember, the dentin, all you have to do is just keep it clean, because these have self-etching monomers in the self-adhesive cement, so you don't have to use an adhesive agent. but enamel is going to enhance the bond of the cement to the enamel surface. So you want to use phosphoric acid there, okay? And the self-adhesive cements, they're all be dual cure resin cements. And so there's a chemical cure and there's a light cure component to them. And so self-etching capabilities of the self-adhesive cements are poor to demineralize dentin, and therefore to demineralize enamel. And therefore you want to do selective etching of the enamel when you're using the self-adhesive cements. Let me recap that. If I have Reliax Unisem, it's a self-adhesive cement. It doesn't come with an adhesive system. I'm going to squirt it into my crown preparation or onlay, and then I'm going to place it on the tooth structure. The self-etching adhesive is going to work well with the dentin, but not very well with the enamel. Therefore, before using the cement, I'm going to do selective etching of the enamel, and then I'm going to use the cement. Now, for dentin, what I'm going to do is I'm going to clean the dentin from any debris. Okay, when I remove the temporary material, I'm going to use pumice. I'm going to clean the surface, rinse it off very well. Sometimes light intraoral sandblast are very good to clean the surface. If you have a glass ionomer material that you use, it comes with a polyalkylinic acid, 20%. It's a very weak acid, optimum to just clean the surface. You just take it with a cotton pellet or with a micro brush and just scrub the surface with it. It's perfect cleaning the surface. You don't want to use strong chemical agents. Don't use phosphoric. You will demineralize the minerals, demineralize the dentin. You will get rid of the minerals in the dentin. That is very important, the bond of the tooth structure. And never over dry dentin. This is the basic principles of adhesion. You never want to over dry your dentin before cementation process. So now we've prepared our enamel, we've prepared our dentin. Now our tooth is ready. If we have core materials, let's say I've made a cast post and core, or I have composite, or I have a metal amalgam. So what you want to do is you can kind of clean it with a hand instrument, a slight roughening with a diamond burr, light intraoral sandblasting is also recommended. If you have a metal core, you can use a metal primer on it. That will enhance the chemical to that metal material. Metal crowns, again, just like the metal core, what you want to do is a light intraoral sandblasting. You can roughen the surface. You can see this gold crown before I cemented it. It's a roughened surface, sandblasted, very nice and clean. And then I always use the metal primer if I'm using an adhesive resin cement and I'm not using a so that's how we prepare for our metal components, whether it's on the tooth structure or as a indirect restorative material. Now, glass phase ceramics. It's a combination of a micromechanical interlocking using hydrofluoric acid etching with a chemical coupling. We have feldspathic porcelain. You apply your hydrofluoric acid 10% for 60 seconds. Please pay very close attention to the concentration of the acid and also to time that you're applying. These can be detrimental to the outcome of your restoration. If you etch with a higher concentration of an acid, or you etch for a longer period of time or a shorter period of time, it will affect the bond strength to the tooth structure. So you're going to use feldspathic porcelain. You're going to 10% hydrofluoric acid for 60 seconds. Lucite reinforced ceramics like Empress system, 5% hydrofluoric acid for 60 seconds. Lithium disilicate or Emax, very popular ceramic. It's 5% acid for 20 seconds. That's it. This is a scanning electron microscope image of the lithium disilicate surface etching and then after etching. So you can see and appreciate how these micro gaps are going to be formed to enhance the micro mechanical bond to the tooth structure. If you over etch and you see sometimes on the surface chalky excess chalky white appearance on your ceramic, that means salts have developed due to the higher concentration and the longer period for etching of your. Therefore, you need to remove that. Either ultrasonic bathing or light sandblasting will get rid of these salts. So therefore, you have a cleaner. Your ceramic primer, your silane or the adhesive. Usually now they're combined into one. containing the MDP monomer, and then with the ceramic material you can use a light or a dual cure resin-based cement. For zirconia, this is an area that has been researched extensively, and if you have proper resistance and retention form, then just use any conventional cement. You can use Rely Extruding Plus, it will work absolutely fine. But if you want to bond zirconia, then you must follow these meticulous in great detail. It's a mechanical pretreatment followed by a chemical pretreatment. You're going to do airborne particle abrasion of your zirconia restoration. That's with 50 micron of 50 micron sandblasting, 15 seconds, 2.5 pressure of bar. The time of the sandblasting all plays a very important role into sandblasting your zirconia. You can intraoral sandblast with 25 to 30 of your sand particles for about 10 seconds. And then your chemical pretreatment, you're gonna add a ceramic primer. Usually the primers have silane and also the adhesive containing the MDP monomer, which is going to enhance the chemical bond to the tooth structure. Always use IvoClean. If you have a crown, zirconia crown, you're going to try it in the patient's mouth, and then when you take it out and you're ready to cement, this surface is contaminated. The very lipids and proteins from the saliva and blood, if you have around the gingiva, will contaminate the zirconia surface. Nothing will get that cleaned off. You can't steam it with air or water or phosphoric acid, hydrofluoric acid. Nothing will clean it properly unless IvoClean, which is one of the products that is available. Now there's 2 or 3 other products available from multiple manufacturers, all claiming the ability to zirconia very, very well. And so using the IvoClean, after you're trying, you apply it for 20 seconds, and then you wash it, and then you apply your ceramic primer, and then it'll be ready for cementing. Whenever I apply the primer on the zirconia, I always wait 3 to 4 minutes because zirconia is a very dense material. You want the primer to penetrate as deep as possible. Study on the use of IvoClean, but you can see here what they've concluded is that you can see when they put the primer on a contaminated surface, you can see that it dropped to 11 from the 25 initial bond strength to the tooth structure. And so when they applied IvoClean, it went up. And so every time you try in, you want to make sure that you apply IvoClean first. So you can see we tried it in, we applied IvoClean, and then your ceramic primer, and you can see the bond strength went up. Also, if you don't have IvoClean, you can use air particle abrasion. After your trial, go and apply air particle abrasion on your inside surface. That will clean from the salivary lipids and protein as well. And so either you apply your primer, you try it in, and then water rinse for 20 seconds. That's one of the recommendations, because if you think about it, if you have zirconia and you apply the primer first and then you try it in, the primer is to protect the intaglio surface from contamination. All you have to do is rinse it off with water. But if you have IvoClean, you can try it in, add with it, clean it with IvoClean, or sandblast it, and then apply your ceramic primer. And for cementation, you want to use a cement, whether it's adhesive or Zesla adhesive, but with zirconia, you always want it to be a dual filament. And we published, because zirconia attenuates light, so you want to make sure that that the light penetrates properly. You have to use a proper curing light that will set your cement very, very well. So it has to be a dual cure resin cement. And so what evidence base do we have really on? You can see here, this is a nice clinical review on self-adhesive cements, looked into 15 studies, some of the in vitro studies that involve chewing simulation. But when we compared self-adhesives to conventional cement, the self-adhesives, they can be used as good as the conventional cements. There was a little bit more plaque accumulation around the self-adhesive cements. And so also the self-adhesive cements were comparable in terms of bonding to the tooth structure, just like cements, but marginal adaptation of the adhesive cements were better. To make it easier for you, whenever you're doubting your resistance and retention form, I would really go towards an adhesive cement, because it's going to have a little bit of an enhanced bond strength to the tooth structure. When self-adhesives were compared to conventional cements and adhesive cements, the self-adhesives had less post-operative sensitivity. And so because of the limited trials, you can see that the author is concluding here that the clinical evidence of self-adhesive cements cannot really be assessed properly because of the lack of information that we have. Just to wrap things up, I know I went over my time a little bit, but I really wanted to share with you if you have different dispensing methods of different cements. So in brand, different dispensing method. What we concluded is this is another example of a resin cement. You have powder, liquid, clicker, and you have the auto mix version, which is 4 papers looking into these different types of cements. And so we compared multiple cements of their hand mix version to the auto mix version. We did strength testing to see the mechanical properties. We aged them so that we can see how these cements perform with time. You can see the aging process reduced the properties of the cement, just like we were expecting. But what was interesting is that sometimes when you from a hand mix to an auto mix is newer, you would see that sometimes the properties would drop. And so it is not always recommended to switch to a new system, even though it's the same brand, just because it's a newer cement that's introduced to you. Included was that the mechanical properties of these resin-based cements, they are different based on their way of dispensing, and so the only system that we saw was very consistent when changing from to a clicker to an auto mix was Reliax Unisem. It didn't really change in the properties that much, so kudos to Tho. How that's going to affect clinically is really unknown, but the ultimate conclusion is that easier is not always better. If you want to do a proper bonding to the tooth structure, it takes time. So to jump into a system because it's easier, a number of steps and faster, does not render a better outcome or durability. So just the bottom line here, just take home messages. If you are going to use a cast metal restoration, whether it's gold as an inlay, onlay as a crown, you're going to use a resin modified glass ionomer if you have proper resistance and retention form. And you want to bond it to the tooth, you're going to use a metal primer along with a self-curing resin, chemical cure resin. Okay, that's for cast metal restoration. For porcelain veneers, whether it's feldspathic, I'm going to use a light cure resin cement always, no dual cure. For ceramic crowns, inlays and onlays, if they have minimal retention, we're going to use an adhesive cement. And also, if they have a little bit better resistance retention form, we're going to use a self-adhesive cement. These can be dual curing. And then also, don't forget etching your enamel. It's going to bond the cement a lot better. And if you have endodontic dowels, you're going to use a primer along with a self-curing resin cement is going to be important. And I've seen many use self-adhesive resin cements, but again, you cannot rely on the chemical component all the time. And so before I wrap up, I wanted to share with you cement retained implant restorations. There's been a big concern about excess cement around these implants and how they can lead to peri-implantitis. And so this is a very, very big problem. 74% of disease healed after cement removal, but we want to avoid peri-implantitis. And so cementing your crown on an implant, you want to make sure that these cements that you're using, you can detect them on the radiograph. And so you can see that on the radiograph, you can't see any of them. And especially the resin-based cement. So it's always recommended to use a cement that has zinc in it. And that way you're able to detect it on a radiograph. Resin-based cements, you cannot detect the cements. You cannot detect the cement in the radiograph. Premier implant cement for cementing implants is invisible in a radiograph, so you can't really see it at all. And so a very you want is to take with a putty an impression of your inside of the crown, and then you place your cement and you go back and place it into the putty. It will squirt out the excess cement, have a nice even distribution. You can go back and cement that with very minimal excess cement. So residual excess cement is associated with peri-implant disease. resin sac radio density versus zinc containing resin cements that are radio opaque, and then abutment with good retention. You can use zinc oxide eugenol, zinc phosphate with poor retention, maybe a zinc phosphate cement or something that has zinc containing in it, so that you can see it in the x-ray and you can clean it properly. I apologize too fast here, but I wanted to include you all. Thank you all so much for your attention. Again, it is unfortunate that I could not be there with you, but I really do hope that you have benefited over the last 50 minutes. And I really sincerely hope to see you sometime soon, inshallah ta'ala. That is my email, Sulaiman, at social media contacts. If you needed to send me anything, any question that you may have on this topic or any other topic, that answer you. And if I don't know the answer, I will find it for you. So thank you all very much. Jazakumullah khair. And I really sincerely appreciate the opportunity of being here over video with all of you. Alaikum wa rahmatullah.